Hello, everyone. I'm Mary Beth Marsden, and thank you for joining us today for GBMC's Ask the Oncologist. Today, we are so happy to have with us Dr. Mei Tang, who is a medical oncologist and hematologist with the Sandra and Malcolm Berman Cancer Institute at GBMC, and she joins us now to take many of your questions that you've already written in and just have a conversation about what she does. Dr. Tang, thank you so much for being with us.
Thank you. Thank you for having me here.
I didn't say it in the beginning, you are obviously an oncologist and a hematologist, but we're focusing a lot of the conversation today on lung cancer, is that right?
Yes.
And
yeah, that's also my research interest.
yeah, talk about that a little bit. Why is that your focus? Or how is that your
Right.
focus?
So lung cancer is one of the major cancer that still a life-threatening condition, especially in advanced stage. I started very early in my career, focused on lung cancer during my fellowship training, and I've been involved in clinical research more than 15 years in lung cancer and the more advanced targeted therapy and immunotherapy in lung cancer.
And even though I know the rate of smoking is down, we're still seeing quite a bit of lung cancer cases, is that right?
That is true. Smoking is associated with lung cancer, but doesn't mean people smoke will definitely get lung cancer. Vice versa, people who never smoke, younger, like a 30-year-old, still can get lung cancer.
And you mentioned that you don't have to smoke to get lung cancer, which is really scary for a lot of people because it becomes so unpredictable then.
It is. There is a group of patients nowadays, we see them in their young age. Typical American lung cancer patients are in their age 60s to 70s. That's based on the Medicare database or SEER database. But we also see a group of young patients who are in their 30s, 40s can develop lung cancer. So my advice for patient is, or for general population is, if you have a chronic cough more than 2 weeks, you should bring this to your primary care or to medical attention.
So is the chronic cough the number one symptom?
It can be, but lung cancer can be so sneaky, and a lot of patients don't have any symptom till it really affected their breathing, shortness of breath during exercise, or chest pain. Those are non-specific symptoms because there are way too many other symptoms can lead to those symptoms. Too many other diseases can lead to those symptoms. So the symptom is non-specific, but more important is bring that to the medical professionals so we can do the imaging, we can do the testing to differentiate what is more important, what need to be evaluated further.
Dr. Tang, before we get to the questions that have already been submitted for you and some that are coming in now live as well, I was just wondering, when you talked about the symptoms and how non-specific they can be, how I could picture it being so easy for people to let them go for a long period of time. And I'm wondering if you have noticed yet, because of COVID-19, that a number of people who should have gotten seen sooner by a doctor hesitated and maybe are presenting now with more advanced cancer.
Yeah, that certainly is a concern because of the patient concern to go to medical facility or seek for medical care during the pandemic. I do not have a statistic number to share with the public yet, but that is something I think in the oncology society we are tracking, we are following.
Yeah. One of the questions we had, and that is, what are the different types of lung cancers? How many are there?
Yes. Um, this, lung cancer is a diagnosis under microscope. So, we can have symptom which lead to imaging. Most time it's a chest X-ray or CT scan. So when you have those imaging abnormalities that would lead to further evaluation, um, most likely it's a biopsy somehow, some way, either under CT guidance or a bronchoscope. Um, but cancer is a diagnosis under the microscope. That tissue is the issue. So we need to have piece of tissue from the abnormality to make the diagnosis. So when we get to that, lung cancer has two major categories. One is called small cell lung cancer, which is about 15% of the lung cancer. But the majority of lung cancer is so-called non-small cell lung cancer. About, not too long ago, maybe 15 years ago, we are still focusing on adenocarcinoma, squamous cell carcinoma, large cell carcinoma, or neuroendocrine carcinoma. But nowadays, we are also focused on the molecular characteristics of the lung cancer. Because of that, actually, lung cancer nowadays is break down into many, many different subgroups, which is related to the treatment.
Right, which informs how you treat it, right? Depending on how.
Exactly. Yeah.
So someone had asked, who obviously has some knowledge about it, what are the subgroups of non-small cell lung cancer? Or is it too many to
Very
name?
good question. Yeah, very good question. So non-small cell lung cancer under the microscope that break down to the two major groups with some minor groups that by the morphology, so what the cell look like under the microscope. So the squamous cell carcinoma, about 30%, another 35% would be adenocarcinoma plus other cell type. This is on the cell level. But when we drill down to the molecular level nowadays, we're profiling the non-small cell lung cancer based on the genetic features and then the markers on the cell surface. We actually will specific tease out the EGFR mutation positive group of non-small cell lung cancer or ALK gene rearrangement related non-small cell lung cancer. And that list going on and on. Currently, there are 9 different subgroups. We grouped the patients that they have specific targeted therapy.
Does this make lung cancer one of the more complicated cancers to treat?
The classification is actually very helpful. Nowadays, because we have the tool, we have the next generation sequencing that come from the Human Genome Project, we understand the lung cancer better than 15 years ago. So it makes us to have more tools in the toolbox to attack this deadly disease. So it's very exciting to have those current technology to support our diagnosis, subclassification, and further treatment.
So great strides have been made in the last 15 years.
Yes.
And someone also asked why it's important to review pathology reports and staging. I think you touched a little bit on the pathology.
Yes. So lung cancer, especially early stage lung cancer, surgery and possibly surgery alone is the curative treatment. But when we talk about more advanced stage, such as stage 3B or stage 4, surgery won't be able to cure the patient. So the treatment paradigm shift to radiation and systemic treatment. And the goal of treatment could be different too. So that's why the staging is important. And also that staging also linked to prognosis. So stage 1 patient, 75% patient would be cured 3 years, 5 years down the line. But talking about stage 4 patients, traditionally or in history, that only 5% patient would be cured 5 years later. But, thanks to the new treatment, new classification, we have more and more patients live to beyond 5 years nowadays.
So the outcomes are improving.
Yes.
It used to be thought years ago that if you were diagnosed with lung cancer at all, it was likely going to be a stage 3 or a stage 4. No one was catching it early. Are we seeing more stage 1 and stage 2s?
This is such a great question. So, to catch up lung cancer in early stage, we rely on the screening. So just not too long ago, we finally have a proven screening tool to use in high-risk patients. We still don't have a general screening tool for general population. So to catch up the early stage is very important. That's still a question remain to be answered in the future.
And who would be considered high risk?
Yeah, so currently is for patient heavy smoker who smoked more than 30 pack years, who are in their 60, 70-year-old. So that's actually does not cover the patients who never smoked, who are also in that age group with lung cancer. So we still need a screening tool for those patients. Can it be a liquid biopsy? So in my dream, one day we will be able to just send a tube of blood and we can screening all the common cancer. Would that be possible?
Yes, yeah. that would be a good thing. Is lung cancer in general slow growing or fast growing, or it just depends?
Depends, depending on the histology. And also the more we understand the genetic component of the cancer, that also play an important role. Also is the patient, if a patient has an intact immune system, comparing to a patient who has autoimmune disease or post-transplant on immunosuppressant, or a patient who have a second cancer like CLL, chronic lymphocytic leukemia, those patients, their immune system is not intact. They could have more aggressive course of disease in general.
Someone wrote in and asked, what should a patient expect after receiving a stage 4 or a recurrent lung cancer diagnosis?
Yeah, that's a very stressful moment for patient and for patient family. That's actually, unfortunately, that's more than 50% of lung cancer patients on diagnosis. And that's majority of patients we see as a medical oncologist. So I think my role as medical oncologist to help my patient family at that moment is really to help them to get the more accurate, subclassified diagnosis and accurate staging, and use those information to guide us to the treatment.
What is adjuvant therapy and what are the benefits?
Yeah, that's a so adjuvant therapy refers to the treatment that patient receive after surgery. So we know even stage 1 lung cancer has 25% risk of recurrence. If we talk about stage 2 or stage 3A patients, the recurrence is high after surgery. So what can we do to reduce that risk? So the current, this is actually just published last year, is besides chemotherapy, we are screening subgroup, specific subgroup of patient who carries EGFR mutation. They will receive targeted therapy 3 years after chemotherapy, and the progression-free survival is significantly better than patient receive just chemotherapy. So adjuvant therapy do save more life in those patients.
Someone would like to know, can iron deficiency be a sign of cancer, specifically mesothelioma?
No, this is not necessarily directly related at all. So iron deficiency, I usually tell, I'm also a hematologist, so I do see a group of my patients with iron deficiency. So iron deficiency is very simple. Somebody don't absorb iron or they lose iron somehow, some way, right? But mesothelioma has very specific risk factors. For example, like exposure to asbestos. So history matters. So I don't think a patient with iron deficiency, which is such a common problem in childbearing age women or someone with lower GI bleeding, I don't think they should worry about mesothelioma. But then if they had exposure to asbestos, then or their family had a history of mesothelioma, then they should consider evaluation.
Dr. Tang, what do we know so far about how these cancers develop, and what can we do to prevent them, if anything, besides quitting smoking?
So, right, yeah. So lung cancer, one major factor, if you consider the median age of lung cancer is around 60 to 70-year-old, after Second World War, average American don't live to 70-year-old, but nowadays average American life expectancy is 85, 86, slightly higher for women. That's why the lung cancer become a common disease in that age group. So we certainly need to help to screening patient and then to address that.
Yeah, what is the recommendation for screening after, let's say, 60?
There's no general screening. Like for breast cancer, mammogram is recommended for all women, age 40 or 50, depending on which guideline you follow. But for lung cancer, it's only targeted at the high-risk group patients, the smoker, the 60 to 75-year-old. So not everyone have a screening.
And is that because of concerns of radiation or false positives or?
Yeah, that is part of it. But also when you're screening, you should have, if you have a concern come out from the screening, how do you address it? When you approach that with your biopsy, would that hurt a patient or benefit a patient? So that involves not individual patient. It's actually a population study, more prospective population study. Only those study can address this question, not by individual case.
Someone is curious about the clinical trials, the program that that is happening at GBMC. Can you talk about maybe some trials that you're involved in or that are happening right now?
Yes, yeah. So we have a very active clinical trial department that involves all disease, cancer-specific trials. So in lung cancer, we actually have adjuvant trial. Those trials are targeted patients after surgery, and we have trials for patients with stage 4 lung cancer when they were just diagnosed or when they have disease progression. We also have a specific trial for a patient who's stage 3. Stage 3 is a group of patients that early stage 3 patient would go for surgery, but more advanced stage 3 patient we will have concurrent chemoradiation. We actually participated in a trial called Pacific trial, which lead to the adjuvant maintenance immunotherapy approval by FDA in stage 3 patients. So only by doing clinical trial we can advance the treatment for our patients.
Someone wants to know if you believe that smokers should be screened at a younger age.
Yes, that actually is, if you really think about this question, this is a wonderful question. So smoking, we used to teach residents, smoking documentation is how many packs a day, how many years you smoke. But if you consider smoking, there are patients light it up, put it away, light it up, put it away. There are patients who smokes every bit of that cigarette, whole day long, all day long. So those are different patients. So, age and then detailed history of smoking, that all affect the risks. And also the patient themselves, if I have a family member who smoked and had a lung cancer, should I be screened earlier, right? So those are the questions not answered by the population study yet. So, definitely, lung cancer is a scary diagnosis for patient family. But I don't want people live under the fear, live under the shadow of that, fear. That's not a good way to live every day, So I would want to ask general questions, how I'm doing, am I having any symptom? If I'm doing well, I'm at my baseline, I don't have any symptom, I don't have any other risk factors. Live the best. There's no way to live under fear.
We used to be told that if you quit smoking after a number of years, the lungs would repair themselves somehow. Is that still believed to be true?
I'm not sure certain things the lung can repair, so sometimes I use this example for my patient, may not be the best, but I will share with you, just like a lung, like a sponge. It has those air bubbles to exchange the air. It's very, very sensitive to any irritation from the air. So the smoking definitely adds more stress to those cells. Over years, those cells can be damaged and become irreversible. But quit smoking is always good. Smoking not only affects the cells in the lung, the airway, it also affects blood vessels, and it's a risk for stroke and heart attack.
Do you have, or could you share your thoughts on any natural or alternative therapies?
I think that actually has a very general definition and can be a big scope of things, can be medication, can be music, can be physical, can be yoga, can be tai chi, can be mindful practice. I think if a patient do believe that and feel that is beneficial to them, as oncologists, I do not against them to use those methods or work with someone to guide them through during their treatment. But I would caution them to use medication, even it's over-the-counter kind of nutrition supplement. During the chemotherapy or systemic treatment, we recommend patients don't combine it. But if they need further help, GBMC has a wonderful integrative medicine group leading by our physician, Dr. Caramonti. So I actually, all my patients I refer to her only have good words about their service. They actually support patients, support them very well during the treatment. But it works for some patients when they have that idea, they want to explore it. We do all have that to offer to our patients.
Treat the whole patient. Dr. Tang, as we know, the use of nicotine is declining, but other ingesting or breathing in other irritants are on the rise. And one that comes to mind is marijuana. And more people maybe are smoking it now. It's certainly become more acceptable and legal in many cases. I've heard that it's particularly harsh on the lungs.
So that we only have like possibly short-term inflammation change, but I don't think there is any convincing data to say smoking marijuana is related to increased case of lung cancer.
Okay. How about, we had a lot of questions about breast cancer, some about pancreatic cancer, and I know that lung cancer is more your specialty, but how does lung cancer relate to other cancers in the body, and where is it closely related?
Yeah, so I want to make sure it is clear. So when we talk about lung cancer, we're talking about some kind of cancer start from the lung. I have patients come in who actually had a previous breast cancer with metastatic disease, meaning breast cancer went to the lung and they thought they have lung cancer. That's not the way we classify them. Those patients, we would classify them as breast cancer metastatic into the lung. So, nowadays there is a group of patients we found that they have specific genes, carry the genes in the family that could potentially increase their risk of lung cancer, breast cancer, or pancreatic cancer. Currently, nationwide, there is a program to screening every single pancreatic cancer patient for their genetic profile, genetic profiling the cancer. So that way we can gather in more information to define the high-risk group or high-risk family. So in terms of that, actually, as oncologists, we screening every patient when they come in for cancer diagnosis. We screen their family history. If they have, for example, two family members with cancer diagnosis, for example, who has breast cancer, early onset breast cancer with a family member with ovarian cancer, that's definitely a patient I'm going to refer to my genetic specialist in GBMC. So we have a program called Hereditary Cancer Risk Assessment. That is a program we have specialists work in the group to screen the patient and family for their potential hereditary risks related to their cancer diagnosis.
Okay, it is time for us to wrap, but I'd love to just squeak in one more question if that's all right with you. And it has to do, and it feels very timely, it has to do with the recent findings that the Johnson & Johnson COVID vaccine may cause blood clots. This person asked, can it affect those components in the blood, plasma, hemoglobins, et cetera, which are impacted by smoldering multiple myeloma? Very
Yeah.
specific question.
Yes, it's a very, very specific question. So we actually don't have those data because even you look at the Johnson Johnson report for a patient who has clotting issues after the vaccine, it's a very small group. That actually was reviewed by the FDA recently, and it's not significantly higher than general population without the vaccine. So that's why currently the vaccine is back on the market.
All right. Dr. Mei Tang, thank you so much for taking time out of your busy day, medical oncologist and hematologist at the Sandra and Malcolm Berman Cancer Institute at GBMC. A pleasure speaking with you today.
Thank you. Happy to help.
And thank you for joining us.
Thank you.